Healing Hands Health Society presents Dental Webinar Series. We have planned a series dental webinars to keep you abreast of current practice. This series on prosthodontics will be via Zoom, Facebook Live. Presenters are drawn from dental schools in the USA, private practitioners from around the world. To register for future webinars, visit www.hhands.org/dental-training. For future inquiries, contact Facillitator.
Dr. Daniel Cortes is an assistant professor at the Ohio State University College of Dentistry in Columbus, Ohio. His work centers around removable partial prosthodontics. Dr. Cortes earned his DDS from the Universidad Autonoma de Nuevo León from Mexico, followed by his master's in prosthodontics at the University of Michigan. He had practiced for 4 years after dental school and decided to take his career in prosthodontics to the next level. Thank you so much for your willingness to participate in our program, and welcome to Dental Webinar Series, Dr. Cortes.
Thank you. I really appreciate the invitation, and it's my pleasure to be helping you in this kind of project that you're doing, that it's really remarkable what you're doing, so I'm really happy to participate.
All right.
Perfect. All right. You're able to see it there?
Yes.
Great. Let me just hide that camera. There you go. All right. So good morning, everyone, and thank you for tuning in today's webinar. And like I was saying, if you guys have been joining us these past few weeks on these webinars, this is the second part of the first one that Dr. Gobea, a good friend of mine, talked about ceramics. He did all the hard work explaining about each ceramic. So today I would like only to present clinical aspects of this. When to do it, you know, how we approach these patients in the sense that, okay, we have to know about the history, what's the previous experience with the dentist, so we can choose the right ceramic for these patients. So I'm gonna be, you know, telling a little bit of a story for each patient, you know, what happened, what they bring them here, what's the chief concern of them, right? Before I start, I would like to just introduce a little bit. Oh, there you go. So as we were saying,
I'm seeing your, can you share your screen?
Yes. Is that?
For some reason, I'm seeing your photograph as the main picture somehow.
Let me just do it again. Does that work?
Yes.
All right. Good?
Yeah, you want to start from the top so I can get a
Yeah.
better recording. Thank you.
There you go. So, like I was saying, I'm going to be talking about clinical scenarios, you know, when we take the decision, make the decision, what is going to be the best ceramic for these patients, okay? Before I jump into talking about the patients, I would like to introduce a little bit about myself. I'm from Monterrey, Mexico, north part of Mexico. I did my dental school over there. I graduated in 2012, worked a couple of years in private practice. And I decided, like, okay, I was not very happy with my, you know, studies in the sense that I was not able to provide what my patient need. I didn't feel comfortable. So that's when I applied to University of Michigan to study prosthodontics. I arrived there in 2015 and finished in 2018. After that, I really enjoyed, you know, the academic environment, and I decided to came to Ohio State University as a faculty. So here I am, and we can start talking about today's objectives. So as I was saying, we're going to be telling a little bit of stories of patients that I've seen during residency in Michigan, and to talk about the clinical applications of the ceramics. Also, I would like to talk a little bit about the digital approach and the analog approach about these cases. These cases are full mouth rehabilitations, right? So I will also be talking a little bit about lab work, like what we need to do first before we start prepping the teeth, you know, gathering all the information that is going to be helping you to provide a good treatment for your patient. Just as a reminder, These two slides are from Dr. Gouveia. He, like I was saying, he explained the ceramics. So mainly today, I'm going to be talking about lithium disilicate and zirconia. As a quick reminder, you know, we can find the lithium disilicate in a monolithic or in a veneer version. It can be fabricated as a press and as a milled restoration. For zirconia, it only can be milled. It also can be monolithic, single unit, or veneer with porcelain, right? So mainly today is just going to be these two ceramics that I'm going to be talking, right? So we can have this in consideration. So today we're going to be talking about these three patients, Ed, Greg, and Kate, right? As I was saying, each patient has a different story, and I always treat my patient or approach my patient as if they were, you know, friends, family. I need to know, you know, what are the previous experience with the dentist, you know, just know them a little bit more so I can understand their needs, not just only seeing it as a patient and, okay, this is just a bunch of crowns that are going to happen. Also, and this is personally, when I treat my patients, I want them to feel comfortable, right? If they don't have that willingness to, you know, be working with me, sometimes that connection dentist and patient doesn't work. So the whole time is just gonna be very, you know, stressful for both parties. So that's also an important thing that I take it really personally, that the patient, you know, it's happy, you know, it's committed to the treatment and is willing to move forward. With these three patients, I'm going to briefly talk about the history, the loss of posterior support in some of the cases, establish new vertical dimension, plane of occlusion, and other important factors on these fulma rehabilitations. These ones are also in combination with implants, right? Combination with, you know, time in the sense that we need to try this new vertical dimension. So it's based on phases. First patient, Kate, she comes to the practice, you know, is a typical patient that she has been with a lot of dentists. She's very nervous, it's a very hyperactive person. You know, it's all over the place. She's very nice, you know, but she has been dealing with a lot of problems of clenching, bruxism, you know, a lot of things that happened to her in her life. So you're expecting that, you know, she's going to be a nice patient, but, you know, you have to take things in consideration just to make sure that everything's going to work, right? We start taking intra-oral photos because this is really important for us to be planning, right? So we see that she has good excursive movements, gain and guidance. She lost a premolar, so we're also thinking about restoring that. On the next photo, I'm going to show you the plane of occlusion that is a little bit of an up and down, right? A lot of fracture restorations that she had from previous dentists, and not just because of things going south. It's just her way of, you know, she grinds a lot, bruxism, so we can see a lot of wear patterns all over the place. So we know this is a high stress patient. So things like this, we have to, you know, to be checking while you're seeing your patient so you can choose the right ceramic, right? So previous fractures on restoration, bruxism, clenching habits. She has been wearing a lot of, and I remember this patient came to my practice with a lot of BITESPLINT. Like I've used these ones for the past 2 years, and probably she came with 5 or 6, and all of them with a lot of wear patterns. So, you know, this can just put some red flags on these patients. So the way that we approach this is we're trying to gather all the information to make sure that what we're going to be doing is going to be working, and it's just not going to be another treatment for the patient that is going to be failing. So this, I don't know if people are familiar with the PANTOGRAPH. So this tool will help us record the mandible movements, right? It's more of a diagnose tool where you can see if the patient is going to be having reproducible movements. So we can find a horizontal and a sagittal table, so we can record these movements. And on the front part, it's the Gothic arch that you guys have read on the textbooks. So we can know if the patient has reproducible movements or if things need to be, addressed before we start, placing crowns on these patients. So as I was saying, it's a diagnose tool that is going to help us make the right decision for the patient. This will also help us putting the settings for our full adjustable articulator. All of these tracing have numbers that it's going to be, set on these articulators. So what we're going to be doing is transfer this to the articulator. So eventually the crowns or the restoration that are going to be fabricating, they're going to be within these boundaries that we record on the patient. Okay. So after that, we present the scenario to the patient, the treatment plan, photos. We talk about the gingival architecture, that it was a little bit uneven. We suggest that we can have some periodontal, approach just to enhance the aesthetics of the treatment plan. Patient in this case was not interested, so she only want, nice smile and then be able or to stop future fractures of the teeth. Also, plane of occlusion, you see a roller coaster. We also suggest some orthodontic appliances just to enhance, all those areas before we jump in and put the restoration. Again, the patient was not very interested in this. She has been to a lot of stuff, so she just wants to get, nice teeth and just be able to, smile. So with all of this information, we do the diagnostic wax up, right? And you have to spend time doing this because this is eventually what you're going to be, the result, right? And also this is really important for our professionals. All these phases or treatment plans, the provisionals play a very important role on the success of your treatment plan, okay? So eventually this was transferred to the patient, right? So we prep. We also place the implant, right? We let it heal. While it was healing, we went to prep all the teeth, anterior guidance, good posterior support, good excursive movements. So everything, it's within the scope of the treatment plan. So after this, right, we were ready to restore the implant that we placed, right, and to take the final impression. This specific patient was an analog, so just a conventional impression, right? We can see here, so a two-chord technique. As you see on the photo, it's a little bit long, but that was meant in purpose just to be able to retrieve it when we were able to, to take our final impression, right? And I'm like I was saying, I'm going to talk a little bit about the lab portion, right? So we have our two impressions, and most of this work, as you've been doing, Uvoh, in your residency, right? We have to pour, we have to pin, we have to fabricate everything. So a good way, right, for us to be able to trim the die is just before we pour the impression, we can block around. I don't know if you're able to see on the right photo, right, with wax, base plate wax, all the surrounding around the preps. So when we pour this, we're gonna have this positive of wax, so it's easy to just flick from that cast, and we're able to trim and read our margins, right? This, as a dental student, I didn't know. So when I got to the residency, I was like, wow, this is really easy for me to be able to, read my margin as I'm doing my work, my lab work. So an important part is that, okay, how I'm gonna be able to articulate this, right, on the articulator that I already have the settings, but how I'm gonna keep my vertical dimension that I established from my diagnostic wax up. So with these ones, this is Duralay or GC copings, right? So we fabricate this on a duplicate of my final impression. I'm never gonna use my actual final impression to fabricate this, because you tend to damage as you're fabricating the coping. So I duplicate that, right? So I have those copings made out of GC. So eventually these GC copings or Duralay copings are gonna be placed on the patient, right? With the help of my provisionals that are gonna be establishing, right? Or making stops for my vertical dimension. So in this case, on the photo on the upper part, we have the posterior provisionals maintaining my vertical dimension. So I place my copings on 6 and 11, 22 and 27 for me to be able to match that. Then eventually, I remove my posterior provisionals, leave my copings on the interior, determine the vertical dimension, and then jump to the back to the posterior teeth to do the same. Right? So in this case, I'm just gonna pull back a little bit. In this case, we knew that the patient, we were gonna expect a lot of forces or a lot of stress in her teeth. So we make the decision to do a monolithic zirconia, okay? So with this, we were able to, establish a good plane of occlusion. We didn't increase the vertical dimension, right? Because she had a good vertical dimension. The only thing that it was uneven was the plane of occlusion, right? So reproducing, her existing vertical dimension, just providing good excursive movement, centering stops, and with our zirconia monolithic restorations, we were able to achieve this, right? So the implants are restored. There are a few things that I should address it, in a different way. For example, the abutments for my implants, I don't know if you're able to see on this photo, they were a little bit dark because I used titanium, right? I should have used zirconia abutment just to have a clear, background. Even though that it's zirconia, it was a little bit translucent. So I was able to see that, shadow or darkness in that area where the patient, she didn't mind. She was really, really happy with the result. On the right lower photo, as I was saying, the plane of occlusion, I was suggesting just to do a little bit of ortho, just to intrude the teeth a little bit, so I'm able to get a nice plane of occlusion. But, she was happy. Patient is, wearing this probably almost to 5 years now, of course, with the follow-ups. And also these, the patient has to commit on the cleanings, on, being compliant on the checkups, because it's not just a one-time thing and then you forget about the patient and then that's it. Okay, so you have to make that commitment. The patient has to do that commitment with you. So the next patient that I'm going to be talking about, it's Ed, right? Similar scenario, comes to the practice. He was not aware about his problems. He only, he was there just because he didn't like the way that he was smiling or how the smile looked, right? He thought that he was, just my enamel is weak and, it is what it is, right? But as you're going to see, a lot of things was happening here, a lot of fraction, abrasion as well. Patient, he was bruxism, was clenching. So those aspects are gonna raise flags for our treatment, right? So we know that the patient, right, it's also it's a high stress patient, right? So from these aspects, we're gonna be taking the considerations, right? From the lateral aspect, canines 22, 27, very worn from the buccal aspect. So this patient, Ed, right, was approached in two different scenarios, digital and analog, right? Sometimes, just trying to approach a patient in a digital way, it's doable, but I mean, you always have to have the background of your analog, perspective. And you also have to do the analog way for you to be able to deliver everything as it's supposed to be. So I did an intra-oral scanner, print this, and do a diagnostic wax up, a potential diagnostic wax up of how things are going to look. So we present to the patient. He agrees. We didn't have to adjust the vertical dimension, right? So eventually, this was transferred to the patient as we were prepping, right? And also the provisionals, they tell us a lot about how things are going to be, on the long run, right? So this is kind of like a test drive for the patient. So he's going to tell us, okay, when I say certain words, it sounds funny. my jaw hurts in the morning, and things like this that, you know, we're going to be taking in consideration or good feedback for our final restoration, so we can make modifications, right? So with the provisional, the patient is, you know, having anterior guidance, eccentric movements, right? Good occlusal bilateral centric stops. That it's the ideal, you know, as we're restoring these patients. All right, so we were ready to take the final impression. Like I was saying, we did this using an intraoral scanner, right? We have everything ready to go. And one thing that I like to do or to give to my patients before I take either my scanner or my final impression, you know, 2 weeks before the appointment, you know, for the final impression, you know, prescribe the patient chlorhexidine so the gums are nice, you know, they're not inflamed. And also the provisionals, they play an important role on this, you know, having a healthy soft tissue for you to be able to do a good impression. Right, so using the intraoral scanner, I was able to capture everything. And as you've seen, and as the previous presenters have talked about scanners, you know, it's pretty straightforward, right? It's not as hard for the patient, you know, to have a, you know, the mouth full of material impression, right? It's fast. You're able to select your margin, right? So if things are looking a little bit shady, you can go back, you know, scan again, and then you can fix that. So eventually I get this, right? The whole maxilla and mandibular full mouth impression using the scanner. Then eventually I print this, right? But then I need to be able to articulate this with the established vertical dimension. So we did the same as Kate using the GC. That's why I'm going back to the analog world using the digital, right? So I have my posterior provisionals. I fabricate anterior GC copings, right? Eventually I will add, you know, material in between these copings to have the support, and then do the same on the posterior. So then this gets transferred to my printed model, right? That was articulated using a Facebook, right? So it's a little bit of both. Now I know that I'm gonna be restoring this with zirconia, right? I know that the properties of the zirconia for this specific patient will be ideal or will be helping the patient. So this is the result, right? And for this specific patient, I use veneer porcelain on the anterior just for aesthetics, right? And I will talk about a little bit about veneering zirconia, you know, excuse me, the potential things that they might go bad having a veneered porcelain on the zirconia. But in this case, the patient had good eccentric, you know, movements. Everything was as ideal as possible. So, you know, I went forward on having, you know, the 6 anteriors veneered with porcelain. Right? So this is the result. Everything, gums, everything looks very, very nice. Right? The 6 anteriors, like I was saying, veneer with porcelain so we can enhance the aesthetics. And actually the monolithic zirconia that was used on the posterior also looked pretty good. So we can you know, see the canine guidance here, anterior protrusive movement. So we have that an anterior guidance that we're looking for. And of course the BITESPLINT. This is a must thing for this patient. That for my previous patient Kate, you know, we delivered the BITESPLINT, but I was not, you know, I didn't took photos for that patient. But so this one, the important thing with the BITESPLINT is reproducing these movements as well, right? So canine guidance, centric stops, right? Anterior guidance. You see with the articulating paper, even bilateral stops for the patient. So, you know, the patient, you know, with this not very nice smile, we were able to achieve this nice, you know, wide, very, you know, even result for the patient. My third patient, it was a little bit of mix of implants, restorative and removable as well. So this patient comes to my practice. He got implants placed, right? And he only wanted the implants to be restored. He didn't care about what was going on the posterior part, right? So as you're able to see on the anterior area, there's one healing abutment, but there's two more implants in that 7, 8, and 9, position. But like I was saying, he only wants to have the implants restored. And, you know, after close examination, we're lacking of posterior support, we're lacking of restorative space. So we explain this to the patient, and he understands that, you know, it's not just the implants to be restored. So the implants being there with no space is just gonna be, you know, a catastrophic failure if we just put crowns on those implants. So we talk with the patient, we let them know that we need to restore everything for us to be able to gain space, right? To set a new vertical dimension. So using a BITESPLINT, right? This is also kind of like a test drive for the patient to try this new vertical dimension, right? I throw these 3 denture teeth just for aesthetic purposes, right? But, you know, following the principles of canine guidance, anterior guidance, centric subs, bilateral, right? And we let the patient use this for a couple of months, well, a month, and well, it was almost 2 months, right? So we know that this vertical dimension is good for the patient, it's not causing trouble. So we were ready to move forward with this, right? At the same time, we're planning to place the implants to restore the posterior support, right? So we can see the difference here between space, right? Patient didn't have nothing there of space on the upper photo, and then we were able to set this new vertical dimension for the patient, right? So as the time was used with the BITESPLINT, we placed the implants on the mandible to restore the posterior support, right? So we were ready to start putting the provisionals, right? So here, tissue management also plays an important role for aesthetics, right? So we were prepping, right? We let the provisionals also, you know, help us manage or do the architecture for our soft tissue, which in this case, you know, the soft tissue was not ideal, but the patient didn't want to, you know, do some connective graft or anything. He just wanted to get, you know, get the crowns there, right? So nice smile there for the provisionals. This way was also, or this patient was also a combination of digital and analog, right? So we're ready to take the analog impression, right? We do a custom coping, right? The custom coping is gonna be able for me to capture my soft tissue that my provisional, you know, did or for the past weeks, and for me to be able to fabricate the final restoration, okay? The same day, we put scanning post for the implants to do a digital intraoral scan, right? And this is kind of like the same. We have the provisionals, we take it out, we put the post so the tissue doesn't collapse and I lose my architecture from the soft tissue, right? We have the digital version of the patient. Those posts, eventually, they're gonna be transferred for the analogs that are my implants, right, for the mandibular portion. And the tricky part of this patient was for me to be able to articulate things, right? The digital approach didn't help me a lot because the bite, or for me to be able to set it on the articulator, was very, very difficult. So that's why I used the analog, right? I was able to, you know, achieve the vertical dimension established using copings, right? The GC. This is the proposed of how things are gonna look for the implant restorations, right? So we have these small 3-unit, fixed partial, bar there for the implants that eventually is going to be zirconia. And then on the mandible, we have these 2 splint crowns for the implants as well. So the GC got scanned, then eventually gets milled in zirconia. We do a final try-in of the zirconia bar, right? That eventually is going to be the restoration. We also choose the porcelain for the gums, right? We use zirconia for this patient, right? For the implant restoration, porcelain on the gums to mimic the soft tissue. Zirconia as well on the opposing arch. Right, so we can see the day of the delivery. The soft tissue is nice. We're following that contour for the soft tissue. We place our implant restoration. The gums, it's a little bit lighter, but patient was okay with that. And then we were ready for delivery. Then for the mandibular anterior, right, we decide to do veneers using lithium disilicate, right? So we deliver everything that it was on the upper photo, right? Everything was zirconia, and then we jump to prep veneers on the mandible using lithium disilicate, right? Minimal prep, just having some space for our material restoration, and then the final result. And from this patient, there were, a few things that I should have done different, maybe putting the preps, the veneer preps a little bit more interproximal, so I don't see the transition from the tooth and the restoration, right? If you're really picky there, you can see that transition, right? But we can see from the left and the right, we establish a new vertical dimension. We restore the implants, right? We restore the posterior support that is really important for us to be achieving a good, and more long-term result for the patient, right? So these 3 patients, they have different scenarios, but similar things where the patients, there are, high stress patients, right? They're lacking of posterior support. So having or taking those areas in consideration, we're able to choose the right ceramic for the patient. I'm going to talk a little bit about the pros and cons of these, ceramics, right? Where Dr. Gouveia did a great job of explaining this, but just a quick reminder. So the pros from lithium disilicate, we have optical characteristics, very translucent, right? It's favorable to abrasiveness, marginal accuracy and internal fit is excellent. It's high strength of adhesion, right? So we were able to bond really good from the substrate, right? It can be monolithic and layered, right? For the zirconia, it's the mechanical properties that are one of the indications for this, right? Favorable to wear behavior as well. We can use it as an implant abutment for aesthetic sites, right? Marginal accuracy and internal fit. One of the principal characteristics of the zirconia is the crack hindering potential, the transformation toughening that it's, excuse me, that is, indicated for the zirconia. It can also be monolithic or layered, right? A few of the cons, right? The lithium disilicate chipping from the veneering, which is from both, right? If we have that transition between, the lithium disilicate and the porcelain, there's always, a potential fracture area for the restoration, right? For both, we have to take in consideration, adjust occlusal adjustment intraorally, where it has to be with low speed, irrigation. So we're not able to introduce, stress for the restoration that eventually is not going to be good for it, right? The glaze that eventually they put to the restoration sometimes can increase the wear, right? And certain articles have shown that glaze, eventually is gonna either come off, but at the very beginning, it might affect the opposing dentition. Okay. Ugo, if we have time, I would like to show the other case, but I don't know how we're doing with time.
So you're good.
Oh, we're good? Okay. So I would like to show, Ugo asked me if I can show my case for the American Board of Prosthodontics. So just for those people that they don't know, the prosthodontic, when we graduate, we have to challenge ourselves for these exams to be able to be a certified prosthodontics, right? So there are a few exams that we have to take for us to be able to call ourselves, I'm a board certified prosthodontic, right? One of them, it's a written exam, and the other exams, which is 3 more, right? It's a case scenario and patient scenarios where you treat your patient either with a complete denture opposing a implant fixed denture, or there are different scenarios where it's removable opposing fixed and things like that. This one in specific, it's a complete maxillary denture opposing an implant fixed partial denture, okay? So got the patient, and this is most the photos, right? This is how we're gonna be, adapting or doing the presentation, because this eventually is gonna be, examined by 3 or 4 judges. They're gonna be asking questions as you're moving forward with this patient, right? So it's most about the photos that I want to show. It's not about the treatment itself. Okay. So the full on the face profile without the prosthesis. And I apologize about the photos. This patient, I was treating this patient during March of this year, and I wasn't able to take all the photos due to the pandemic, and the patient is returning just to complete those missing photos. So we evaluate the intraoral photos. The patient comes with existing implants, right? They were placed outside prior practice, and as you're gonna see in a couple of seconds, the position of the implants, the most distal, they're a little bit tight there, right? Then for me to be able to restore this, I would like you to have a better path of withdrawal instead of, these 2 most distal implants just hitting. So I measure my soft tissue thickness for me to be able to put a multi-unit abutment to enhance the position of the existing implants, okay? So we take a preliminary impression of the implants, right, just to choose the multi-unit abutment, right? So this is just to choose the multi-unit. Then, as you see on the distal, the most distal on the left, I was able to put a 30, it was a 15-degree angle multi-unit, right, for me to be able to move the position of that implant a little bit more towards the distal. All right, then we jump for the conventional way of treating the maxillary denture, border molding, concentrate your tissue stops, right? And everything has to be, good for the photo, because this eventually is going to be evaluated by the examiners, right? So light body impression for your maxillary denture, the copings for your multi-unit abutment level impression copings, right? We attach everything just for stabilization when we're taking our final impression using GC, you see. Custom tray, border molding as well for the distal portion. Medium body and light body for the final impression. And then when we have our final cast, right, we have to verify the position that you took taking the impression, that it's the same as the patient. Sometimes we have a little bit of movement, right? So if that happens, we need to verify, or we need to adjust that. So the way to verify this is attaching the copings to your cast impression. We secure them with Duralay, and then it has to sit on the patient in a passive way, right? We do what we call a 1-screw test. So if we screw one of these copings, everything has to be, going down in a passive way. I also like to do this using plaster, mounting plaster. if the impression or where you fabricate this in the cast is not passive, right? It's gonna break. And you can see very, very nice if it's not the same as your cast and of the patient, you'll see a fracture on that jig that you're doing to verify the position. All right, then just the conventional way of treating complete dentures, wax rims, your CR record. And then we do the wax try-in, right? So here we're aiming for a lingual occlusion, right? We do the aesthetic try-in, it's wax, the patient is able, to do the phonetics, aesthetics, all that, things that you guys know about complete dentures. On both sides. Like I was saying, this is just photos, right, that you're gonna be, taking, that eventually you're gonna be presenting to the examiners, right? We send these to get the titanium bar fabricated. So they send the proposed design of how things are gonna look, right? We do the good to go, and they mill the bar for the implants, right? This is the intaglio part of the bar that is usually, concave. We don't want convex areas that are gonna be, potential areas of food getting trapped. Very polished, nice, and preventing from areas to get caught the plaque there. Right? We have to make sure that we don't have a lot of, distal cantilevers that are gonna be, creating a lever effect for the implants that we don't want. Right? The intaglio, and all of this, we have to process them ourselves because we have to take photos. So we have to process the denture, we have to process the implant prosthesis as well, right? Which we have it in another different presentation, but I didn't, put it here. As well here, the delivery appointment, everything is looking good. The important part here is the discursive movement, because they're really, really picky that you're actually achieving a lingualized occlusion and not something else that it shouldn't be there. All right. Lateral view. And then these, we have to take a final impression, doing a pickup impression of the prosthesis, right? And eventually mounting an articulator. So as we're presenting this, they have the articulator with the prosthesis there, so they're able to, reproduce the movements that they're seeing on the photos. All right. Then without the prosthesis, again, and then with the prosthesis. And thank you so much for your time. Like I was saying, this was just a little bit of photos of how things should be presented for the American Board of, Prosthodontics exam. Thank you so much. Thank you very much. That was really, really cool presentation by Dr. Cortes here. I'm going to there's a poll, some questions based on this presentation. I'm going to I have to make sure I find the right one. All right. Yeah, so
Healing Hands Health Society presents Dental Webinar Series. We have planned a series dental webinars to keep you abreast of current practice. This series on prosthodontics will be via Zoom, Facebook Live. Presenters are drawn from dental schools in the USA, private practitioners from around the world. To register for future webinars, visit www.hhands.org/dental-training. For future inquiries, contact Facillitator